Thank you very much, Ken. Good evening, everyone. First of all, let me begin by thanking the organizers for giving me this opportunity to do the plenary presentation today. It really is an honor to be here. And it is a special honor because I also presented at the first of these summits. And I remember very clearly it was a very difficult meeting because CDC had just released our new recommendations, revised recommendations on HIV screening. And in this room at that time, I believe there was both excitement about these new recommendations, but also some fear and trepidation about this very aggressive move and very important move of CDC to really look differently at HIV testing. Now, over the last 7 years, as you've heard, there have been huge advances in the field, and my role this evening is really to do a few things. I've been asked to reflect on where we are with the epidemic of HIV and viral hepatitis in the United States, and I've also been asked to share with you some of the new and exciting programs that we're implementing at the CDC as we embark upon and continue this journey to both look differently at these epidemics and to implement impactful programs that can both get rid of the infections, but also ensure that we're working to address health inequities here in the United States and to promote greater collaboration between agencies. This presentation is also a bit poignant for me because it's my last major presentation in the United States before I leave the CDC on the 21st of December. And I would be remiss if I didn't begin the presentation by saying thank you for your leadership and your work and your contributions to the fight against these infectious diseases over the last 7 years, and indeed since the beginning of the HIV epidemic, and of course in the journey that we've gone together over the past few years in really scaling up our response to hepatitis. I have been blessed to work with so many great leaders at the CDC, great staff at the CDC, but I've been equally blessed to work with many academic partners, community partners, those of you on the coalface doing the work that needs to be done. So thank you. So I'll begin by reflecting on the HIV epidemic in the US. And I know all of you in the room are very much aware of where we are with the epidemic, but I think as we begin to frame the conversations for the next 3 days, I think it's important to go back to basics to understand where we are with the epidemic, what are some of the key drivers, and where are some of the opportunities for really making a dent in the epidemic moving forward. Now, there are more than 1.1 million Americans who are currently living with HIV, and as you know, the prevalence of HIV has been gradually and sustainedly increasing in the United States over the past decade as more people are living healthier and longer lives with HIV. Each year, we see just about 50,000 new HIV infections which occur in the United States, and this number has been relatively stable over the past decade, although that stability hides quite a lot of heterogeneity across gender, transmission categories, etc. The good news is that we are not only seeing individuals living longer and healthier lives with HIV, but we are seeing declines in the HIV transmission rate in the United States. But we need to have more aggressive efforts to ensure that we continue to see not only stabilization in HIV incidence, but true declines in HIV incidence as a key part of getting ahead of the curve and creating an AIDS-free generation. So if we dig a little bit deeper with the prevalent diagnosed infections in the US, we see some very remarkable changes that have occurred over the past 30 years. A reduction in the proportion of HIV-infected individuals who are undiagnosed has been a major accomplishment of the US response. Currently, about 20% of people living with HIV are undiagnosed in the United States. But this figure has to continue to decline, and part of our efforts to drive that decline will be scaling up HIV testing, diagnosis, and linkage to care. When we look at HIV incidence in the US, again, as I mentioned earlier, we see a lot of heterogeneity across the transmission categories in the United States. The good news is that we're seeing sustained declines in HIV incidence among injecting drug users in the US, about an 80% reduction since the 1980s. We're seeing reductions in HIV incidence, or certainly stabilization in many heterosexual men and women in the United States as well. The only group where we're continuing to see year-on-year increases in HIV incidence remains gay and bisexual men. And some of the most significant increases that we're observing are among Black gay and bisexual men, especially young Black men who have sex with men in the United States. And throughout the presentation, I'll be coming back to this unique statistic and about what we need to do to get ahead of that curve. But we are seeing tremendous differences in HIV incidence by transmission category, by gender, by age group, despite the overall figure of HIV incidence remaining relatively stable. Now, the HIV epidemic in the US, as you are all well aware, is characterized by tremendous health inequities. And here, I really wanted to begin by highlighting the disparities which exist between gender and HIV incidence in the United States, as well as by race ethnicity within gender within the United States. In 2009, the rate of new HIV infections for Black men in the US was more than 6 times as high as that for white men, and about 2.5 times as high as that for Latino men in the United States. We are seeing stabilization in new HIV infections in women, and CDC will be releasing new data on HIV incidence shortly, which will, I think, show very promising trends in what's happening with HIV incidence among women in the United States. Nevertheless, among women, we see tremendous disparities across the racial and ethnic groups. Black women are 15 times more likely to have the rates of new HIV infections are 15 times higher than that of white women and 3 times higher than that of Hispanic and Latino women. And I think to drive this point home of the health inequities in the US, today in the US, if you are a Black man, you have a 1 in 16 chance of being diagnosed with HIV in your lifetime. And if you're a Black woman, you have a 1 in 32 chance of being diagnosed with HIV. This should not be happening on our watch 3 decades, 4 decades into this epidemic. And this is why this summit is going to be critical, not only to think about our new approaches for testing, diagnosis, and care, but how within this we address some of the health inequities which are a hallmark of the epidemic in the United States. Another key hallmark of the epidemic is the severe and disproportionate burden of disease borne by gay and bisexual men in the United States. And we see a number of key differences across the racial and ethnic groups when it comes to the proportion of new infections which are occurring. And here in this slide is basically here to illustrate that among Black, gay, and bisexual men, we see a disproportionate burden of new HIV infections occurring in the youngest age group, those aged 13 to 29, as opposed to white, gay, and bisexual men, where we see a relatively equal distribution of new infections occurring in the age groups 13 to 29, 13 to 39, and above. This concentration of new HIV infections among young Black, gay, and bisexual men has already been alluded to by Ken Mayer, and I'm sure will be a key element of your discussions over the next couple of days. Another key element of the epidemic is the geographic concentration of the disease, and in part this is a reflection of the demographic distribution of risk populations in the United States. We're seeing an increasing concentration of disease in the southeastern parts of the US, and 4 states account for about 50% of persons living with a diagnosis of HIV infection: New York, California, Florida, and Texas. But if we look at new diagnoses which are occurring and the concentration of these diagnoses among African Americans and gay and bisexual men, we're beginning to see southeastern states taking the lead in some of the new burden of disease in the US. Again, Ken has already alluded to the continuum of HIV care in the United States, and we do not perform well relative to other Western industrialized countries with the continuum of care, and this is certainly going to be an area for us to continue strengthening and accelerating our response in the years ahead. I'm going to transition now to reflect on hepatitis, viral hepatitis in the United States. And as with HIV, I'll begin by an overview of the epidemic patterns, and then I'll be looking at some of the key populations for focus in our efforts. As many of you are aware, we've been seeing declining trends in acute hepatitis B in the United States, in part a result of a very successful vaccine-based elimination strategy which was implemented in 1991 and increasing child vaccine coverage. Nevertheless, today we see about 95% of new hepatitis B infections occurring in adults in the United States, And we see tremendous differences in terms of risk groups which are affected by acute Hep B, including those who are occupationally exposed, dialysis patients, men who have sex with men, injecting drug users, and STD clinics. As a result of the very effective vaccine campaign in the US, we see the lowest rates among young persons in the United States, with increasing rates of disease among older cohorts of adults in the US who have not benefited from the childhood vaccination program. In terms of chronic Hep B in the US, we see an estimated prevalence of about 700,000 to 1.4 million in the United States. And again, we see tremendous heterogeneity across racial and ethnic groups in the US, with a disproportionate burden of disease being borne by those of Asian Pacific Islander heritage. But we also see disproportionate burden of disease among migrant populations in the United States. And I've just shown here data from a population survey of 6,300 African refugees in the Atlanta area, which reported an 11% prevalence of hepatitis B surface antigen. Again, we see not only the high prevalence of disease among Asian Americans, but we see the disproportionate burden of high morbidity and mortality within this group. Transitioning then to an overview of hepatitis C epidemiology in the United States. As you're all very much aware, hepatitis C is a major cause of liver disease in the US. We see about 400,000 of 114,000 persons who are awaiting liver transplants who are HCV infected, and about 50% of all persons with liver cancer being HCV infected in the US. Now, not only are we seeing HCV as a major cause of liver disease, but we're also seeing increasing trends in HCV disease in the US, as well as increases in mortality. And this increasing mortality and burden of disease is associated with increasing costs, as highlighted here on this slide. HCV is associated with about $21,000 in annual healthcare costs versus $5,500 for other healthcare issues. And HCV clearance via therapy actually reduces annual healthcare costs by nearly a half. So for some reason, a number of my slides are not showing up today, and I'm going to attribute that to Providence, because I've been told the secretary is going to be arriving shortly, so I'm going to shorten the presentation. So things do work out absolutely perfectly. The slide that preceded this one was really going to show that we've been seeing declining trends in HCV, hepatitis C, HCV diagnoses in the United States over the past 2 decades, in part a response to the availability both of effective screening programs as well as effective treatments which have been available, as well as the responses to reduce HCV among blood transfusion recipients and among injecting drug users. Nevertheless, this is no cause for complacency, because more recently we have been seeing increases in HCV. Certainly for 2010, we saw an increase of about 1,400 cases of HCV reported in the United States. Many of these increases, new diagnoses, were seen among young adults in the United States. A key element of our work at the CDC over the past few years has been looking at expanding the at-risk populations and increasing our understanding of who's at risk for hepatitis C in the United States. And many of you are aware that we have been focused on the high burden of disease of HCV infection, chronic HCV infection. And most recently, we have been articulating the need for a birth cohort strategy to address the high burden of disease among those who were born between 1945 and 1965. Now, approximately 1 in 30 Americans in that age cohort are infected with HCV, and this represents about 81% of HCV adult chronic HCV infections. We know that there are tremendous healthcare needs for this population. About 67% have medical insurance. About 45% report no risk for HCV, and yet they represent nearly 73% of HCV-associated mortality. Finally, to bring both epidemics together, I wanted to briefly reflect on HIV and viral hepatitis co-infection. Again, I know many of the abstracts at this meeting will be focusing on this. About 25% of individuals who are infected with HIV in the United States are also infected with HCV. And we know that injecting drug users, about 80% of IDUs with HIV infection are also infected with HCV. We also know that the syndemic also is observed for hepatitis B virus infection in the United States, with about 10% of HIV-infected individuals being infected with HBV, and about 20% of new HBV infections in the US are among men who have sex with men. HIV co-infection actually increases by triples the risk for liver disease, liver failure, as well as liver-related deaths from HCV. And CDC currently recommends that all HIV-infected persons should be actually tested and screened for HCV and HBV. Now, in the final part of the presentation, I really wanted to transition to quickly reflect on the new strategic approaches that we have nationally, which I think are real game changers in the response to these viral infections in the United States. Ken and others have already mentioned the US National HIV/AIDS Strategy as a key game changer, and I've highlighted here the vision for the National AIDS Strategy, which I won't go through in the interest of time, but which I know that you're all very familiar with. What is clear in this vision for the strategy is its focus on addressing health inequities, and its focus on moving away from individual level determinants of disease transmission to have a more comprehensive response to the epidemic in the United States through addressing the social and structural drivers of the epidemic. And if we are serious about bringing the epidemic to an end, this will have to be a key element of our conversations about this response in the years ahead. CDC is an active participant and an active implementer of the strategy. We are fully aligned with the 3 goals of the national strategy, which are to reduce HIV incidence, to increase access to care, and also to reduce HIV-related health disparities. And as the lead agency for prevention, we work very closely with a range of our federal partners and private sector partners to accelerate the implementation of the strategy. A key element of the CDC response following the release of the strategy 2 years ago was the development of our own strategy, the high-impact approach to HIV prevention, which really takes the key elements of the strategy but makes it real for the work that we're doing in prevention. And the key element of high-impact prevention is ensuring that the right interventions are selected, that they're targeted for the populations in greatest need, and brought to scale to have the maximum population-level impact. Key components of high-impact prevention are highlighted here. We're focusing on the effectiveness and cost-effectiveness of interventions, the feasibility of full-scale implementation, having and ensuring coverage for targeted populations, and of course, issues related to the prioritization of interventions and how interventions interact with each other as we're targeting them to particular population subgroups. A key element of our high-impact prevention approach is ensuring that we're preventing the most HIV and promoting health equity as part of our prevention response. Now, the high-impact prevention approach has been implemented in a number of ways for us at CDC, and many of you who are grantees who have CDC grants would have seen over the last 2 to 3 years that we have been driving grantees and our partners to focus on some of the most highly efficacious and the interventions which are likely to have maximum population level impact. And these include scaling up HIV testing, scaling up and really thinking differently about HIV prevention with HIV positive individuals, having new conversations about scaling up access to and utilization of condoms and really thinking differently about condom distribution in the United States. And for the first time as an agency, really focusing on the social and structural determinants of HIV, including the role of health policy as a key lever to support interventions which are occurring at the individual as well as at the community and partnership level. So one of the things that we're keen to do as part of our prevention response is to create an enabling environment for optimal HIV prevention and care through policies, regulations, and practice. Over the last 2 years, since the release of the National HIV/AIDS Strategy, CDC has released a raft of new funding initiatives or has continued to bring to scale a number of long-standing initiatives which are completely aligned with the HIV high-impact prevention approach. I've highlighted 4 of our flagship initiatives which have been implemented since the release of the National HIV/AIDS Strategy, the first being our Enhanced Comprehensive HIV Prevention and Planning Project, which really was a demonstration project to look at the feasibility and acceptability of greater collaboration and integration, not only at the national level, but at the local level to enhance our prevention, treatment, and care initiatives. We have expanded our HIV testing initiative, which began in 2007, and during the first 3 years, we were able to test more than 2.8 million individuals, diagnose more than 18,000 persons, the majority of whom were in high-risk populations and communities, including African Americans and Latinos. We estimate that to date we've averted more than 3,000 HIV infections as a result of this initiative alone in the United States. More recently, we've revamped our CDC flagship health department FOA, and we've been doing a lot of work to realign the prevention resources with today's epidemic, and that has meant taking from jurisdictions which were funded more richly relative to the current epidemics and ensuring that there was a more equitable distribution of funding and aligning current funding with a high-impact prevention approach. And most recently, one of our newest initiatives is the Care and Prevention in the United States initiative, which is a demonstration project which is looking specifically at the prevention, treatment, and care cascade and ways in which we should be supporting health departments to do a much better job, not only of testing and linking people to care, but for using surveillance data to help to maintain individuals in care and to drive increases in the proportion of HIV-infected persons who are maximally virally suppressed. Awards have been made to jurisdictions predominantly in the southeastern parts of the United States, and this initiative has been funded in partnership with our colleagues at the Department of Health and Human Services through the Secretary's Minority AIDS Initiative. So these are some examples of ways in which we have taken the language and the intent of the National HIV/AIDS Strategy and are moving into very rapid implementation at the CDC. In this slide, I really wanted to highlight the goal of the National Viral Hepatitis Action Plan, which was the second major strategic plan that we have worked with our colleagues across the Department of Health to develop over the past 3 years. And the goal of the National Viral Hepatitis Plan is to ensure that cases of viral hepatitis are prevented, that persons who are already infected are tested, and that they're informed about their infection and provided with counseling, care, and treatment. Many of you are aware of the contents of the plan, so I won't be going through this in any great detail, but suffice it to say, CDC has been an active partner in the development of the plan and now in the implementation of the plan. And key elements of the plan are included here, involved with educating providers and communities, scaling up testing, care, and treatment, strengthening surveillance, eliminating transmission, and of course addressing risk behaviors which are driving viral hepatitis transmission in the United States. Now, a key element of our leadership at the CDC has really been to look at new ways and approaches of addressing the highly prevalent condition of HCV in the United States. And many of you are aware of the recent release of our revised recommendations for Hep C testing in the US, which adopts a birth cohort approach for individuals born between 1945 and 65, as we earlier discussed. In addition to this, through a number of fantastic supports that we have received through the Department of Health and Human Services, we've been able to invest new resources in scaling up our hepatitis prevention approaches at the CDC. So in the last year, we've been awarded nearly $10 million in funding from the Affordable Care Act's Public Health and Prevention Fund. And we've been using this to really look at ways in which we should be accelerating implementation of the National Viral Hepatitis Action Plan. We're funding 32 organizations to expand testing for hepatitis B and C in the United States and to enhance linkage to care, treatment, and prevention. And we're also scaling up education efforts, again, with the use of these new funds through new social marketing campaigns, the No More Hepatitis campaigns, as well as campaigns which are targeting both at-risk communities as well as provider communities in the United States. So in summary, I've been given the task to provide an overview of where we are with the epidemics of HIV and hepatitis in the United States, and really to share with you some of the new approaches that we're implementing at the CDC in response to not only the evolving epidemiology, but new strategic approaches which are now in place. Clearly, we are dealing with highly prevalent conditions, both for HIV and viral hepatitis. I think the new national strategic plans provide both a sense of purpose, as well as unique opportunities for us to do better and to do better faster when it comes to addressing these epidemics. But a key part of the response, as we've mentioned throughout my presentation, will not only be addressing the cascade of treatment, prevention, and care, but really asking tough questions about who is infected with these diseases and why are they continuing to be infected with these diseases, and what more can we do to address the severe health disparities that we observe here in the United States. I will argue that future success in the US will certainly depend on our ability to implement what we know what works, to bring those to scale, and to ensure that we're focusing resolutely on those at greatest risk while expanding our knowledge base and improving implementation of our interventions. And I look forward to reading about your progress from across the Atlantic, but I'm sure that I will not be able to let go of this wonderful experience in leading this program here in the US. Thank you so much.